So I move to this now. The national rollout of COVID vaccinations has begun with the over 60s. And while off to a slow start, it is hoped that as new sites open up, daily inoculation rates will tick up fast. At the same time, there are concerns about global supply. Here at home, at least 3 provinces are in a third wave, albeit in the early stages. Let's get a comprehensive look at COVID-19 in South Africa currently. I'm joined now by Professor Salim Abdool Karim, Director of Caprisa, that's the Centre for the AIDS Programme of Research in South Africa, also the Caprisa Professor of Global Health at Columbia University and a member of the recently formed WHO Science Panel. Professor, always so great to chat to you. You've done a latest crunch of what the numbers are saying in answer to the question, are we as a country in a third wave? Talk us through what you're seeing.
Yes, very good evening, Sally, and good evening to all of the viewers. When we look at the 7-day moving average, we are now at a level at around 2,762 cases. When we were at this level in the first and second waves, in 14 days later, we had about 5,000 cases. So if this current trajectory follows what we saw in the first and the second waves, we can expect that the number of cases is going to continue to increase. And within the next 2 weeks, we're going to hit around 5,000 cases. And that's being driven by a few provinces at this early stage. But what we are likely to see is a way in which all of the provinces will eventually start, and then we'll get a coalescence that leads us to the peak. So if you look at this diagram, you can see how the first wave occurred, and that's in the blue line, and then the second wave went much faster because it was a more transmissible variant. Now, if you plot the first and second waves one over the other, and then look at the current trajectory, you get some idea of where we are in the third wave. So we're at a very early stage of the third wave, and if it continues like this, the trajectory we're going to see is about 5,000 cases in about 2 weeks' time. Now, the importance of that is that in order to see 5,000 cases in 2 weeks, those 5,000 infections need to occur now. So that's why it becomes important that we have a clear idea about where we're going, because we need to act early. If we wait for 2 weeks, those 5,000 cases have already occurred, and now will be closer to 10,000 infections occurring.
Can I just come in on the 5,000 cases? One of my colleagues, who's much better with numbers than I am, Michael Marilia, crunched the numbers and how you determine whether you're in a third wave. And it's about once you're a third of the way up the previous wave, and it works out to around 5,000 to 6,000 cases a day over a rolling 7-day period. So that 5,000 cases, you say if we carry on as we are, in 2 weeks we're going to be hitting 5,000. So that says to me, and correct me if I'm wrong, that if we don't do something dramatic now to stop our behaviour and to stop transmission, within 2 weeks the country will be in its third wave.
Yeah, you've hit it very clearly. I would just add one rider, and that is that if the third wave, and if our current trajectory follows what we saw in the first and second waves, then we are likely to be at 5,000 cases in 2 weeks' time. We have a window, and right now we have a window of a few days in which we need to act in order to avert that kind of situation.
Of course, we also know that the second wave was driven much higher by the identification of the 501YV2 variant, which has sort of 3 significant mutations that have really made it more transmissible. Am I correct that we're not seeing any new and worrying mutations at this point?
When we look for variants, we do surveillance, and that is we collect samples from swabs across the country, and then we sequence them, and we do bioinformatics. That process takes about a month. So our genomic surveillance is always several weeks behind schedule. In other words, we will know in the end of May what was happening in April. So we have to go on that basis that we don't know it in real time. So given where we are and what we know now, we are seeing cases of the B117 variant. We are seeing a few imported cases of the B1617 variant from India. The B117 is from the UK originally. So when we look at those variants, they are not at this point at a level that we are concerned about. However, the B117 can spread quite rapidly. And my concern is that we're already starting to see some of those variants in the provinces where we are seeing a very rapid rise in cases, and that's in the Free State and in the Northern Cape. So those variants, we're not overly concerned because they share mutations with the 501YV2 variant. So at this point, no, I am not concerned about variants, but I am concerned that a new variant may arise that we haven't yet found.
All right. I want to ask you about the news from the Independent Electoral Commission. They're appointing a task team to look at whether we can hold local government elections safely at the end of October due to COVID-19. My thoughts on that, and I wonder how you feel, is that until significant vulnerable members of our population are vaccinated, surely it's impossible to predict what the virus might be doing in October in South Africa, and therefore quite risky. Should we rather not be looking at having an election once significant members of the population have been vaccinated?
So there are two ways of looking at it. We don't know what the future holds in terms of this disease. Every time I think I know it, something comes across that changes the trajectory. So we don't know whether, same time next year we'll be dealing with a new variant that escapes vaccine immunity and we're back to square one. So we don't know what next year looks like. We're hoping that our vaccines will continue to protect us into the future. So the way I would look at it is, where are we likely to be in around October this year? And we will be, in all likelihood, in a period of low transmission. So we will be seeing quite few number of cases. During that period, the risk of transmission is generally low because we've accumulated immunity, our behaviors are appropriate, and our restrictions are keeping the virus in check. The elections will pose a problem if they are mass super-spreading events. But other than that, with regards to queuing, with regards to other things, we have been able to deal with those things, because as long as we do most of that out in the open, it's not really a problem. So I would say it's more important to understand where the trajectory will be in October and to get some idea of when might it be different, and to hope, if you're going to postpone it, you've got to hope that next year October is going to be better than this year October. Mm-hmm. And that's difficult to predict.
That's quite terrifying to hear you say that, because, of course, here in South Africa, we are so excited that we're seeing the proper rollout of the vaccine program begin, with the over 60s starting to get vaccinated. Of course, it's slow going because there's still some 700,000 healthcare workers who remain to be vaccinated. The Johnson & Johnson jab has not been released thanks to the Baltimore mix-up in the USA. We're waiting for that to get the green light. And then, of course, we hear from the Serum Institute of India that they've got to prioritise their people at home, so they're not releasing their stocks, which is going to affect COVAX. If I ask you to put on your WHO science panel hat now, how concerned are you about global supply of this vaccine?
I'm quite deeply concerned. I'm deeply concerned because of the huge disparity that we have. I'm particularly concerned that we have a situation where some countries have so much in terms of vaccines that they are now vaccinating adolescents that are at very low risk of infection, while in Africa, we haven't even been able to complete vaccinating healthcare workers in several countries. So this kind of uneven distribution is creating a problem that goes beyond the overall supply. It's not just that we don't have enough vaccines, we have a maldistribution in the vaccines. And that is going to cause a problem, because there is no scenario in this world where one country will vaccinate its population and try and create some kind of island where it will be protected while the virus is spreading rampantly in the rest of the world. There is no scenario that that's a success. This is a pandemic. It needs a pandemic solution, which means it needs a global solution, which means we need to vaccinate at roughly equal levels across the globe, because that's how you suppress the virus. It doesn't work if it's spreading wildly in one place and another, because when it spreads like that, it encourages the emergence of variants.
Well, I am very glad that your voice and your view is being heard on the WHO Global Science Panel, because that message needs to be heard loud and clear. And thank you so much for chatting to us. And there you heard it from Professor Salim Abdool Karim, Director of Caprisa, the Centre for the AIDS Programme of Research in South Africa.